So I have the pleasure to introduce our first speaker, Dr. Andy Wong.
Actually, Julia is going to go first.
Oh, sorry.
Yeah, Julia Barbaso.
Okay. Sorry.
Hello, everyone. I'm Giulia Marvaso. I'm a radiation oncologist from European Institute of Oncology in Milan. Thanks for the invitation and the opportunity to talk about the role of radiotherapy in this setting. First of all, I have to start with the fact that my presentation will be oriented on the fact of the reintroduction of radiotherapy in the management of renal cell carcinoma, because we have to start from the old concept when radiotherapy was used mainly for palliation in this setting. And this dogma about radioresistance was really strong, but now we have the possibility to deliver radiotherapy in a different way. So evidence has grown that high dose given in one of few fractions can overcome this resistance, and so now we can manage also these patients in the different also history of the disease. This is a really quick look to the NCCN guidelines, when you can notice in the old ones radiotherapy was not mentioned. Things changed in the current guidelines when metastasectomy is currently indicated as an indication with the use of SBRT. When I talk about metastasectomy, for sure I talk about SBRT, but could be done also with the surgery. So starting, I said before, SBRT can be used in all different settings in this kind of patient. I'm speaking about the oligometastatic setting. So in the synchronous oligometastatic setting, metachronous, and also in the oligoprogression. So you can use SBRT in all these different kinds of settings. Just a few words about the radiobiological difference between conventional radiotherapy and the SBRT, because the difference is mainly in the fact that SBRT can increase the induction of endothelial apoptosis, and this depends on the radiation schedule. So for this reason, SBRT could be useful in this setting, because we can overcome radioresistance for this mechanism of action. This is a quick view of the radiobiological aspect. But what about the evidences? Unfortunately, we have a lot of retrospective studies, prospective studies, and meta-analysis of these studies, but randomized trials are missing. As I said before, when I talk about metastasis-direct therapy, I talk about the use of SBRT, as I said before. And starting from this meta-analysis from 2019, with 28 studies included, with a lot of patients and lesions, with the extracranial and intracranial lesions. As you can see, results are quite good, mainly for metastasis in the body, but less with metastasis of bone. Why? Because we cannot increase so much the dose, for example, in spine metastasis, because we have to take in account the toxicity of the cord, for example. But as I said before, those matters. So mainly we can hypofractionate, better is the local control, and also the site of the metastasis and the volume of the metastasis could have to be taken into account. So those of RT matters, single fraction versus hypofractionation, site of metastasis matters, bone versus other site, and also tumor volume. This is a really interesting papers about a group of Timmerman, where the fundamental topic is the use of SBRT to delay the starting or postpone the starting of systemic treatment. And the principal endpoint was the freedom from systemic therapy. As you can see, the results are better with the less number of metastases, for sure, depending also on the risk group, on the histological subtype. But the real question, mainly for a medical oncologist, is when we postpone or interrupt systemic treatment for toxicity, for example, in the combination with the radiotherapy, the delaying of systemic treatment can diminishing or augmented the burden of disease, This is not true, for example, in this case, when we count the months of activity for the drugs and also the time that we spare with radiotherapy, summing both of them, there is 22 months, for example, of months for the patient with the drug alone experience. So take in mind, when we choose patient, because my presentation is also, I want to point out the fact that we have also to select patient and take in mind the time to development of metastasis, also if the patient is a surgical candidate or not, the patient preference, and also the success of metastasectomy is highest with the solitary metastatic lesion, and also about, I talked about the location of the metastasis. This is an Italian experience of the Italian Association of Radiotherapy. As you can see, we have 200 patients divided in oligorecurrent, oligoprogressive, because we can use SBRT, as I said before, in the oligoprogressive setting, when the patient oligoprogress during systemic treatment, to delay the switching to another therapy. As you can see, most common sites were lung or bone, and the results were quite good also in terms of overall survival. At multivariate analysis, only the total number of metastases remained significant. This is a focus on the same group of patients from my institution, where the main point was also the so-called drug holiday, and to postpone the starting of the systemic treatment or during oligoprogression, to put the patient in drug holiday. And the drug treatment rate was 70 hours and 50% and 1 to 2 years for this group of patients with the concomitant systemic treatment. I'm talking about immunotherapy and TKI for sure. And just 2 words about this meta-analysis that came out in European Urology from Shankar Siva, because the results are quite good. 24 studies and more than 500 in the use of SBRT, also in the treatment of primary tumor, but also in intracranial or extracranial metastasis. And I want to point out that the local control range about 90 and 97%, and with a really low grade of toxicity. And also in the delay of systemic treatment was 70-90% of oligometastatic renal cancer patients, with always a grade toxicity very low. And the combination with the systemic treatment or immunotherapy or target therapy appears safe, feasible, and tolerable. So what's the ideal candidate for SBRT? We are really far from the medical oncologist point of view, because also we wanted to do tailored radiotherapy and choose the best patient to do SBRT. So for sure, patient selection should be discussed in a multidisciplinary team, and patient with unresectable disease or unfit for surgery, or also in poor clinical condition. But it's not the point, because we want also to use SBRT in patients fit also for surgery. A clear seal histology for sure is the best one in terms of response, solitary or less of 3 oligometastases. And when we want to postpone, for example, the use of the systemic treatment, metachronous disease with disease-free interval at least of 2 years. Low intermediate risk have been associated with more favorable outcome. And for bone metastasis, we have some trouble with the dose, but I will show you later how we can overcome also this. And tumor volume is important, because small volumes allows RT dose escalation. There are so many questions about patient selection, the use of SBRT, the setting, the dose, so we tried also to answer all these questions with this Delphi consensus on the use of SBRT for oligometastatic renal cell carcinoma. We built a questionnaire of more than 40 questions, and we asked 25 experts. Also, Professor Steller is one from EAU. And unfortunately, after 3 rounds, so many questions are not answered, and divided opinion are are a lot, but we are working on that, and we had also some major agreement or consensus. As I said before, what's the future? The future hopefully will be also with the use of proton therapy. Proton therapy is a different way to deliver radiotherapy that is really different also from the physical point of view. And what I said until now is that, for example, for spine, we have trouble with reaching a higher dose for the toxicity, and hopefully with the dosimetric advantage of particle therapy, we can do better also in this setting. And take-home messages, SBRT offers a good local control within an excellent toxicity profile, is a good option in selected patients with oligometastatic renal carcinoma, is a valid alternative for patients fit, I will say, unfit for surgery and with poor condition. And local approach for the so-called drug holiday improves quality of life. As I said before in many presentations, we are talking about heavily treated patients. And for sure, work together matters. All these patients should be discussed in multidisciplinary teams and with the strict collaboration, for sure, with medical oncologists, radiology, and so on. Thanks for the attention.
Thank you, Dr. Marvazo. Our next speaker is Dr. Andrew Wong, and he is a professor at the UT Southwestern Cancer Center in Texas, and he will be talking about future directions of radiation therapy in kidney cancer.
Thank you for that kind introduction, and it's a pleasure to speak to you this morning. So you heard an excellent talk about how to utilize radiation for RCC treatment today, so I'm not going to dwell on that. So my job here is to talk to you about where we're headed, what are the potential futures for radiation in RCC management. First, I would like to address where we're headed for using radiation for RCC to the primary, to the kidney tumor. The current treatment is limited by the fact that RCCs are less radioresponsive. So using classic radiobiology curves, basically the normal tissue of the kidney response curve and the tumor curve are closer together. And so it's hard to achieve tumor control without inducing a certain level of toxicity. And as you know, for these patients, the kidney function is very important. So what can we do? Well, there are technologies that are being developed that we can separate the curve, so push the tumor curve further to the left, or push the normal tissue further to the right, or both. So what are these efforts? First, radioprotectors. So after several decades of development, finally we're seeing pretty good radioprotectors. These are superoxide dismutase mimetics are coming pretty far along in clinical development. So they're in phase 3 for head and neck cancer, pancreatic cancer, and lung cancer. And so if they achieve success, we should expect these radioprotectors to come to kidney cancer treatment. As you can imagine, that if they can protect the normal kidney from radiation damage, preserve function, then we should see more utilization of SBRT for the primary kidney tumor because it's less invasive and quite beneficial. And then on the other hand is we can also radiosensitize the primary tumor to make it more responsive. Classic radiosensitizers have been chemotherapeutics, which are much less relevant in this setting. However, there are newer classes of radiosensitizers. We have nanoparticle-based high-Z materials. Those require intratumoral injection, so perhaps not as relevant for RCC, since then you can do ablation and other things. But nonetheless, it's possible. Also, there are targeted agents, so DNA damage response inhibitors that are targeted through ADC approach. Those can certainly radiosensitize and improve the tumor response and in turn allow us to treat more primaries with the SBRT. Perhaps the more exciting direction is to utilize radiation to improve IO, especially for this crowd. A majority of you are medical oncology. We know that radiation is pro-immunogenic. We know the abscopal effect, where we all try to achieve, but it's rare. It's not quite unicorn anymore, but nonetheless, we don't see it often. So at UT Southwestern, we're pushing a newer concept of using SBRT to further tune up the IO or immune response. So as you know, SBRT tend to be given in a short course, so within a week or two. And here, we're thinking that we know that vaccines further spaced apart are better than, vaccines given back to back, so the booster effect. So can we do that with radiation as well? So basically, the concept is that we further space out the SBRT fractions or doses, right? So instead of every other day or every few days, how about several weeks? Think of like heartbeat, so make it very long. So we should expect more of a vaccine booster effect, and that perhaps will improve the IO response. This is an example. This is not a kidney cancer patient, but this is a metastatic melanoma patient, and a skin lesion was treated. As you can see, all the liver mets went away. Classic abscopal effect, very robust. I would say that with the Pulsar approach that the department has taken, we're seeing this more often. That's an observation, but we hope to document this rigorously. Another way to tune up the immune response is to add immune adjuvants. So UT Southwestern, we are looking at actually more than one trial looking at adding a STING agonist, which is boosts immune response. So following radiation. And so this would be either in the oligoprogressive or oligometastatic patient, and it's focused on kidney cancer patients. And we believe that if we can generate more immune response from a single site, we could potentially achieve a better systemic response. To share a little bit of our own work, so my lab, we focus on biomedical engineering, so we have engineered antigen capturing nanoparticles to be given after a dose of radiation. And so these nanoparticles can grab onto tumor-derived antigens and do a better job of antigen presentation. In animal data, we have shown that this is a very robust approach to tune up the systemic response to IO. And so the company that's translating this is slated to enter clinical trials first quarter next year. So last but not least, we can also do systemic therapy with systemic radioisotopes, theranostics. There's a lot of excitement in this area, especially with the success of Pluvicto and Lutathera. Pluvicto for prostate cancer right now is we're running out of doses because of the high demand. As you know that, for RCC, actually there's a booth out there. There's girentuximab, that's an imaging agent targeting CA9. And so if that imaging trial succeeds, you would expect that, a therapeutic isotope can easily be substituted and come down to, as a systemic therapy. And I'm sure there are many others are looking at targeting RCCs. Our own group, this is a bit of our own data, is that we recognize that many tumors don't have easily targetable, biomarkers. So, our approach is to engineer one for tumors, so make it a biomarker independent or agnostic approach. So it's a two-step approach. So we can engineer conjugation moiety onto tumor cells, and then we'll target either IO agents or therapeutic isotopes. So this is unpublished data, so this paper is under review. But it's another approach to enable, it's radioisotope, it's radiation, but systemic therapy. Quickly, just want to summarize, there are many opportunities to expand radiation or radiotherapy in RCC treatment. I think there are many exciting developments, and we're probably at the beginning of using radiation in RCC. So many of these opportunities depend on new technologies, which is exciting. And I like to think that we will play a more important role in the future. Thank you very much.
Thank you, Dr. Wang. And it's my pleasure to introduce now Dr. Daniel Hang from the University of Calgary in Canada. And Dr. Hang, as you may know, is also the head of the large network of the EMDC and the founder, I think, of this network. Thank you.
Thank you very much, and a warm hello from Canada. So thank you very much for inviting me here to the program committee. It's a wonderful opportunity to share insights and network and see people again, so it's great. I'm going to talk about prognostication in kidney cancer, and the slides are a little bit different, and go over my favorite subject. So how do we look at prognosis, a patient's prognosis? Where do we go from here? Prognosis is built from a lot of different things. So you heard from Sarah Sutka's presentation about body composition and sarcopenic obesity, the obesity paradox. There's the tumor microenvironment. IRAEs can predict how people do. Tumor burden, the inflammation milieu in the body. And all of these things combine together to create someone's prognosis. We have the IMDC criteria, they're at the very bottom there, but there's so much more. And so we have so much more to learn about patients' prognosis. The IMDC, I'm very lucky to be a part of it, and many people over here play a role as well. Elka, many people in this room actually participate in the IMDC. And we're very lucky to lead studies looking at practice patterns and inform practice and look at sequencing, prognostic factors, outcomes, and I'll show you some of that work right now. So as you know, these are the IMDC prognostic factors. I won't go over them with you. If you have 0 factors, you have favorable risk disease, 1 or 2 factors, intermediate risk, 3 or more factors, poor risk disease. And I just wanted to spend a little bit of time on the diagnosis to treatment less than 1 year thing. This is a common question, and so a few things. The time from initial nephrectomy to first-line systemic therapy is that interval. So if you had a nephrectomy 5 years ago, and then you have metastatic disease now, and then you're not going to start systemic therapy for another year because you're going to do some observation, that treatment duration is actually 6 years. And so it's not time from metastasis to treatment, it's not time from initial diagnosis to metastasis, it's time from diagnosis to treatment. Now, in the age of adjuvant therapy, does adjuvant pembrolizumab count when we calculate this? And the answer is no, because it's for adjuvant therapy. We only count the first systemic therapy for metastatic disease. And finally, when we think about cytoreductive nephrectomy, sometimes we can say, you know, if you have intermediate risk disease and only 1 factor, then maybe we should think about upfront cytoreductive nephrectomy, or at least we can think about it. So how do you calculate it if you haven't started your systemic therapy yet? And that's a very common question as well. And so unfortunately, it's something that you kind of have to guess. So if you have very limited metastatic disease and a large kidney mass, and you think you can do some surveillance after this is cytoreductive nephrectomy, then likely your diagnosis to treatment interval will be less than 1 year. But it does take a little bit of guessing. So this is how the IMDC prognostic factors play out. This is in the age of VEGF-targeted therapy. And so I just wanted to point to your attention that the poor risk group there, the median overall survival is 8 months. So let's keep that number in mind. Here's our website, imdconline.com. So if you can't remember the prognostic factors, you can come here. And we've tried many times to add different prognostic factors to the IMDC model, but SAS always spits out that, oh yeah, it only improved the C index by about 1 or 2%. So that's why we haven't changed it over the years, but trust me, every 6 months I look at it, we press the same statistical package, but nothing seems to come out. We've updated the IMDC criteria since. This is Dr. Matt Ernst. He's one of our IMDC fellows who's worked on this and has published it recently in European Urology. And here's the money slide. And so this is what's changed with IO therapy like Ipi/Nivo on the left-hand panel, IO VEGF therapy like Axi/Pembro, Axi/Avulimab, Cabo/Nivo, Lenvatinib/Pembro. And on the right-hand panel is VEGF therapy, VEGF-targeted therapy. There are a few things that I wanted to point out on this slide. The first is we've made tremendous improvements in overall survival. So you can tell with a VEGF-targeted therapy slide, just goes straight down like that, whereas IO-VEGF and Ipi/Nivo, all of the curves have been pushed up. The second thing to notice is that favorable is always different from intermediate, is always different from poor in all of these graphs. And the third thing to notice is kind of the shapes of the curves. So the VEGF curves goes down. The Ipi/Nivo curve initially goes down, but there might be there might be a plateau after. And the IO-VEGF curves, those curves are still a little bit immature, but you can see they're a little bit more convex. They have better progression-free survival up front. And so they don't go down as quickly, which speaks to the upfront response. You'll notice that there is a favorable risk curve for Ipi/Nivo. We have to interpret that with caution because Ipi/Nivo is not indicated for favorable risk individuals, and these people are usually clinical trials patients or patients that were deemed suitable for Ipi/Nivo by their treater. It's the real world, so stuff happens in the real world. This is the same data in tabular format, and you can see, in terms of overall survival, treatment duration, time to next treatment, favorable risk always does better than intermediate risk, always does better than poor risk. And, just pointing out the Ipi/Nivo number, you can see the 18-month median overall survival, the 18-month survival, 50% of patients are alive. So that means that the median overall survival is 18 months now for a poor risk individual instead of 8 months in the VEGF-targeted therapy era. And here's the response rates. So the overall response rates are always better in the favorable compared to intermediate compared to poor, except for Ipi/Nivo. And that makes sense because we know that in the favorable risk individuals, sunitinib or a VEGF-TKI can do just as well in terms of overall response rate compared to Ipi/Nivo, and that's why Ipi/Nivo is not indicated for favorable risk individuals. So the favorable risk overall response rate for Ipi/Nivo is about 40%, and so is the VEGF-TKI one. What I do want to draw your attention to on this slide is the CR rate. So in all of the clinical trials, we mentioned CR rates of 10%, 12%, 17% for lenvatinib pembrolizumab. But in the real world, things are always different. And so in the real world, the highest we have here is about 6.9%, but the range is between 1.5% to about 7%. So it tempers our expectations for CR. And I think that's really important, that in the real world, things are always different compared to clinical trials. So I did want to spend some time talking about brain metastases, because that's also something that we haven't touched on very much in this meeting. This is Dr. Kosuke Takamura. He's also one of our IMDC fellows that presented at GU ASCO this year. Brain metastases is a prognostic factor. If you have brain metastases, you don't do as well compared to patients without brain metastases. And you can see in the TKI era that was true. In the IO-based era, it's true as well. It's not statistically significant, probably because of lower numbers, but maybe also because of the efficacy of IO-based therapies a little bit in these patients. In terms of first-line therapies, if you look at IO-based therapies for these patients versus TKI-based therapies for these patients, or TKI-only therapies for these patients, you'll notice that there's a difference. And the difference is quite large. It's like doubling. This is a testament to the clinical effectiveness of IO-based combination therapy in patients with brain metastases. This is important because all of the clinical trials have excluded these patients in their trials because we're not supposed to include patients with active brain metastases in these trials. And so we do need data like this to confirm that there is effectiveness in this population as well. What was interesting to me, though, is that things have changed over the years. So from 2004 now to 2022, when we capture that, we do notice that there is a decrease in whole brain radiotherapy use. And I'm so glad I followed a radiation oncologist here because, renal cell carcinoma does require higher doses of radiation to be effective. And so that's why we see a concomitant increase in SRS over the years. So usually we require, oh, it's animated, that's cool. So usually we require higher doses of radiation. Usually we use SRS instead of whole brain radiotherapy. In terms of the Kaplan-Meier curves for overall survival of these brain-directed therapies, I don't want you to pay too much attention to this slide, but the SRS and the neurosurgery group did better than the patients that didn't. But there are obvious reasons for that are biased, right? So patients that get SRS or neurosurgery probably only have 1 or 2 lesions, or they're probably healthier compared to patients who got whole brain radiotherapy, or patients that got patients that with no brain-directed therapy. But what was interesting, though, in this slide was that the no brain-directed therapy cohort was very similar to the whole brain radiotherapy cohort. And so that was very interesting to me, despite the biases in this graph. So the IMDC model continues to risk stratify. Even the age of IO combination therapy. IO combination therapy is the standard of care. Our OS benchmarks, I think, are really exciting. They've all improved, and so we can get a big pat on the back on that. But at the same time, we have to temper our expectations, because what happens in the real world is always less than what happens in the clinical trials. Brain metastases is a prognostic factor, and it requires localized treatment and multidisciplinary care. And it's an exciting space to continue to do research in this. And I want to thank all of the people that contribute to the IMDC, all of the people in this room, because without that we can't inform our practice like this. So thank you very much.
Thank you, Dr. Heng. Our next speaker is Dr. Sophie Kunte, and she is from the Ludwig Maximilian University of Munich, and she will be talking about theranostics in RCC, both diagnostic and therapeutic imaging.
Dear ladies and gentlemen, thank you very much. I'm really pleased to give this talk on behalf of Dr. Unterreiner, who is unfortunately prevented from coming today. So I hope to represent her properly, and I will use the next few minutes to give you a deeper insight into the diagnostic and therapeutic imaging in renal cell carcinoma from a nuclear medicine perspective. So we already heard about theranostics. Theranostics is the most important term if we talk about molecular imaging nowadays. So theranostics is the combination of therapy and diagnostic. We can do this by using the type of radiation in either a therapeutical or in a diagnostical manner. And so far, the most commonly used radioligand for imaging of different tumor entities is FDG, a radioactive labeled glucose. But the problem with renal cell carcinoma is that RCC is hardly avid for FDG, so we need other solutions here. And fortunately, over the last years, novel radiotracers such as PSMA, CMET, and FAPI have been developed. PSMA, most of you will probably know from patients with prostate cancer. It's expressed from the tumor cell itself in patients with prostate cancer. And you can see an example in the picture on my slide. It's a patient with prostate cancer, and the metastasis shows a strong PSMA uptake, especially if you compare it to the commonly used FDG. The other novel tracer that was developed is CMET. CMET is a tyrosine kinase receptor that is overexpressed in some patients with renal cell carcinoma, not in everyone. I will show you some examples later. And we can also use this in the imaging of renal cell carcinoma patients. And the last novel tracer that we've been working with for the last years is FAPI. FAPI is a fibroblast activation protein inhibitor, which binds directly to FAP, the fibroblast activation protein. And FAP is also overexpressed in different tumor entities, and recent study data demonstrated that an overexpression of FAP is associated with tumor aggressivity. The advantage of the novel radiotracers is that we can use them in the setting of theranostics, and this is not possible with FDG. So to summarize my last slide, theranostics is the combination of therapy and diagnostic, and we use the same target structure to do so. So this is our kind of business model in the nuclear medicine. And thus, not only oncologists, but also nuclear medicine physicians are able to offer a personalized therapy in the sense of you treat what you see. So the VISION trial is the buzzword that keeps coming up if we talk about theranostics, because I think this is the most successful trial that used the principle of the theranostical percept. So what did they do? They had patients with prostate cancer. They underwent PSMA PET-CT for staging reasons. Then they underwent lutetium PSMA therapy. And later we can use PSMA PET-CT once again to evaluate the response to the therapy. So the big question is if we can use this kind of concept also in patients with renal cell carcinoma. But there is one big difference between patients with prostate cancer and patients with renal cell carcinoma if we see it from a nuclear medicine perspective, because the PSMA is not expressed in the tumor cell itself, but in the neovasculature in renal cell carcinoma, and this makes it a bit more difficult for us to target the lesions. However, there is an unmet need to develop any kind of biomarker because we don't have a PSA or any other biomarker from the blood. No, we have a biomarker from molecular imaging, so we have to do something here. And otherwise we cannot target any response assessment to tyrosine kinase inhibitors. So this is one example. We implemented in our department a study with PSMA theranostics in patients with renal cell carcinoma. You can see here a patient with a renal cell carcinoma that underwent PET-CT imaging prior to TKI therapy, and you can see hepatic metastasis with a strong PSMA uptake. And after therapy initiation, you can see no uptake anymore. So this might be a hint that the PET might be a useful option to evaluate response assessment to TKI therapy. And additionally, you can see that the metastases were not that good delineable in CT, so here might also be the PET of benefit. We further analyzed the response assessment to TKI therapy in patients with renal cell carcinoma by comparing the response on PET using a modified PERSIST score and the response on CT by using the RECIST 1.1 score. And I don't want to go too much into detail on the slide, but I want to show you that the patients showed a strong heterogeneity. So, for example, this patient presented with progressive disease in PET, whereas she presented with stable disease in CT. And thus might be also a hint that the PET might detect response or even progressive disease prior to CT. And thus maybe PSMA might be a future option for patients with renal cell carcinoma. We also tried to provide PSMA therapy to patients with renal cell carcinoma. We tried this in 2 patients, but as I already mentioned, it's quite difficult because the PSMA is expressed by the neovasculature, and thus it is quickly washed out. So we are still working on this, and the further data are still to be published. So the next tracer I already mentioned is c-MET, the tyrosine kinase receptor, which is also expressed from renal cell carcinoma. And now's the question if this tracer might be an valuable option to assess if a patient should undergo TKI therapy. And I am proud to present the first in-human data of the use of c-MET PET-CT. And you can see here a patient that shows a strong uptake in his primary tumor site, but only in the anterior area. He shows no uptake in the central necrotic area and only an at most sluggish c-Met expression in the dorsal border. So with this example and with the next one, I want to show you the intra- and intra-individual heterogeneity. This patient, for example, presented with pulmonary metastasis, and in picture B and C, you can see that this metastasis did not express any kind of c-Met, whereas the metastasis in picture D and E shown strong c-Met expression. This might also lead to a future kind of lesion-based treatment. At last, I want to mention a really novel and really innovative tracer and trial. It's the SERCON trial. It was first presented at the ASCO of this year, so this is really novel data. And they investigated patients with renal cell carcinoma, or they did not know if it is renal cell carcinoma. They wanted to detect clear cell renal cell carcinoma in patients with a tumor mass of uncertain dignity. So they got an injection of the monoclonal antibody, and after about 5 days, the patients underwent PET-CT imaging, and the detection rate was really high. So we are talking about a really high sensitivity and specificity. And this is really innovative, and I think if this really works in some more patients, they already investigated 300 patients, then this will lead definitely to a change of the development of further radioligands in patients with renal cell carcinoma. And I want to close my talk with an outlook. So I also mentioned FAPI as a novel tracer, which was already implemented in different metastasized tumor entities and showed promising data. But the problem is, as it is demonstrated in this study, the cohorts are really small. So this study only included 1 patient with renal cell carcinoma, so we have to work on this. And this is why we already started to investigate the FAPI uptake in autoradiography in renal cell carcinoma, and we're planning for further in vitro and in vivo studies because there are still questions that have to be answered in the future. So I will want to close my talk with the take-home message. Theranostics is the concept, the combination of therapy and diagnostic. We have novel radiotracers in nuclear medicine, and we can use them not only in a diagnostic but also in a therapeutic manner in the sense of theranostics, and thus we can provide a personalized medicine and a lesion-based therapy in the future for our patients. Thank you very much.
Thank you, Dr. Günther. So this session is open for a discussion, and we will be pleased to take some questions. If not, let's have one question to our radiation therapist, because it's a practical question. Whether we have to stop the systemic treatment during radiotherapy or not.
Are you talking with me?
Yeah, you can.
Actually, we have not so much data about the combination or the interruption. I think it's the choice is usually depends on the institution because, for example, with TKI in my institution, we suspend the treatment for the timing of the radiotherapy. That it's like brief treatments, 10 days. So there are studies showing, retrospective studies showing there are no differences in the tumor outcome, suspending or interrupting. So hopefully we are waiting for clinical trials also answering this question.
Yeah, so my take is that you don't need to do that for IO, and also it's not really practical to stop for IO because, as we know, that IO actually circulate quite a bit longer than the cycles that you give, and there's really no known added toxicity when you combine the two. For TKIs, it's a little bit tricky. I think in general, we like to hold that. It's practical to do it, and also there are some toxicity that we have seen. That said, there are certain situations where the normal tissue nearby is, whatever. If we're irradiating metastasis and the normal tissue nearby is not all that sensitive, I think it's okay to push through. We have done it both ways, but so it is a very much tailored approach.
Yeah, Dr. Tani.
Yeah, thank you. Question to Dr. Heng. Nelly, you showed a slide about brain metastasis treated, in the MDC population, IO-based, so combination with IO-TKI versus TKI. Obviously, the results were better in the IO-based. Is this due to benefit in brain metastasis, or do you think the outcome was driven mostly by better response to systemic therapy, to systemic disease with the IO combination over single agent TKI? My impression is whatever you do with IO, brain metastasis is not really well treated with IO. It's obviously the local therapies, the gamma knife treatment, the stereotactic, rather than the systemic therapy. So my guess is your results are better because of better control of systemic disease with IO-based than single-agent TKI.
Yes, Nazar, you're absolutely right. Our TKIs do not work in the brain. IO therapy might work a little bit in the brain, but it's not nearly enough. And we need localized therapies, neurosurgery or SRS, to control what we have in the brain. So yes, I agree. The curves are due to good local control and good systemic control. And the point of the curve is just that there is still an overall survival benefit despite all of that in patients with active brain metastases.
Yes. So following up similarly on that, and you might have sort of answered this, but in our patient communities, we certainly see patients who have brain mets. Their therapy is often delayed, and especially in the community setting, it might even be delayed longer because they might get treatment, or they get radiation treatment, and then their therapy might be delayed even further. And my question is that impacting that overall survival, and does it change whether the development of brain mets really is prognostic or not? Does that make sense?
Dina, that's a really insightful question. I think whenever we encounter patients with de novo brain mets at the very beginning, I try to deal with that first because that's the most urgent issue. So either with stereotactic radiosurgery or neurosurgery, there can be delays. As I come from a socialized healthcare system, so there are delays, and it does prevent getting your systemic therapy on time. The way we calculated the overall survival was actually from when we started treatment with systemic therapy. So even with that delay, there was still an improvement in overall survival.
It's a question for Dr. Wang. I can't get the CT scan out of my head of the melanoma case with the liver metastases. And I may have missed it, and I apologize if I have missed it. That patient just had radiation to a skin lesion and the metastases went away?
Yeah, so it's the abscopal effect. So the 2012 New England Journal first documented. So going all the way back, I think the first report was in the 1950s, and in training, at least I remember hearing about it. But I joke, but we call it the unicorn event. Everybody documented, but nobody has seen it. But then the 2012 New England Journal paper, it was actually N of 1 melanoma patient, very similar. And so I hope everybody has seen once at least. But yes, so that patient had basically a.
Did you try it in everybody?
I'm sorry?
Did you try it in everybody? I mean, it's mind-blowing.
Well, do we try? Yes, we tried to get this, but it's the signal is very very small. It's not zero. But all the trials actually, if you go into clinicaltrials.gov, there are quite a few trials looking at this. Nobody has seen a large enough signal to report positive data, and hence the subsequent approaches, right? So as a field, we've been struggling with just doing simple trials, so then we're not seeing that high signal. So then the question is, what do we do with that? So the correlatives actually shows that after radiation, you have a vaccine effect. It's just not strong enough to push it all the way, and so the approach will be, 1, space out the treatment so that we maybe, move the needle a little bit more with the booster effect. 2, sting agonists. 3, my own work is antigen presentation. But so it's, probably takes all of the above or some more to get it over the other side. Yeah.
Thank you.
Could radiation oncologists comment on the radiosensitization effect? Should we be exploring that with systemic therapies? Dr. Marvaso.
I think it's already proven in so many types of cancer that definitely we have to go in this way in the next years. And we have so many preclinical data on the radiosensitized effect of immunotherapy with the radiation, but in some way we had some trouble to go in the clinical practice and show them, for example, the abscopal effect is one of them.
Yeah, so obviously I'm a big fan, but I do think RCC is very different because it's not a drug responsive, and so it requires a different approach. So as I mentioned, I think DDRIs, which is developed by quite a few pharma. Those have potential, but the problem is these need to be targeted to tumors. There has to be a differential uptake. And so the companies are recognizing that. They're doing drug delivery approaches. Their approach is more ADC approach. We have our own work on, I'm a nano person, so we have our own approach. But I think combining the two, we should be able to see something positive.
It's exciting.
Thank you. So I think we
can adjourn the session. Thank you.